without further ado, I will introduce Dr. Price and let him go ahead and get started on the presentation.
Tom, thank you very much for the opportunity to talk about the CardioForm Septal Occluder, and I think just in general, PFO closure. We're going to focus today on simple PFO cases, which really I think encompass 85–90% of the cases that you will see. And the rules of the road for a simple case, those fundamentals will serve you very well when you get into complicated or more complex cases. So, and we'll touch upon that as well. And question and answer period, so important. Put in your questions, don't be shy. I will, if I don't answer them during my talk, as I look down and see the questions, we'll address them at the end. So this is your chance. And again, I find that actually the most valuable portion, as do many viewers. So if you have a question, please enter it and we will address it. So first I thought, you know, I see a lot of patients with cryptogenic or PFO related stroke. It's pretty rare that we act when you do the ICE or the TE, you often just see the PFO. It's pretty rare to actually see a DVT at the same time. So I think it's important to remember the mechanism and how morbid a PFO can be. And this is really a case of, I suppose, PFO and paradoxical embolism and form FOOST. This is my friend and colleague Joe Aragon's case. I'll give him credit for this, up at Cottage Hospital in Santa Barbara. So these are his images that he allowed me to present. So this is a 55-year-old female who presented with an acute stroke. And I gather she was hypoxemic as well. So they did a CT scan of the chest, a PE protocol, and they found multiple PEs on her CT scan. A quick duplex ultrasound showed deep venous thromboses of her lower extremity. And they did a transthoracic echo, which showed a positive bubble study. So they sent her for a TEE, and this is actually Joe doing the TEE. So let me play this here. So actually first I'm gonna go back to here. So here you just see on this still image of the long axis view of the interatrial septum. This will be important when we talk about PFO closure. So there are two major views. So the long axis of the septum, so we have the SVC on our right here and this TE, IVC is on our left. This thick part here is the septum secundum. This is the septum primum, left atrial on top, right atrial on the bottom. This is our PFO. Hopefully you guys can see my mouse here. And the arrow here shows the PFO. And this, look at this thing here. This is a thrombus within the tunnel of the PFO itself. And what you're gonna see now is Dr. Aragon rotating his probe to follow that thrombus. And as he rotates through the tunnel, now into the left atrium, you see a massive thrombus in the left atrium actually interacting with the mitral valve itself. So unfortunately, this patient expired from massive stroke due to her paradoxical embolism. So if you're not convinced that PFO can't be a mitigator of or the proximate cause of stroke in patients with venous thrombosis, I don't know what else can prove the point. So this is what we're trying to prevent with PFO closure. And the data is in. So you guys are tuning in to learn how to, or to increase your knowledge base about how to close PFOs. So you may be believers already, but it's also important to know the data, not only to be a believer, but to know the data. Multiple randomized clinical trials have demonstrated that mechanical closure of the PFO is superior to medical therapy or preventing recurrent cryptogenic strokes, generally in patients less than 60 years of age. And this is just data from the REDUCE trial, which was the trial which studied the CardioForm Septal Occluder, randomized versus antiplatelet therapy only. So PFO closure plus antiplatelets versus antiplatelets only at 2 years led to a 71% relative risk reduction in the risk of recurrent stroke. So a clear benefit for PFO closure, which in the end led to FDA approval of this device. And again, I think it's important just to lay down the fundamentals here is what is the indication for PFO closure? This is word for word from the FDA, and it's on the package insert. of the cardioform occluder. So the cardioform septal occluder is indicated for the percutaneous transcatheter closure of a PFO to reduce the risk of recurrent ischemic stroke in patients predominantly between the ages of 18 and 60 who have had a cryptogenic stroke due to a presumed paradoxical embolism as determined by a neurologist and cardiologist following an evaluation to exclude known causes of ischemic stroke. We're not going to go into the workup. I refer you to other GORE educational materials and webcasts, which go into this in gruesome detail. But just some highlights, age is important, but doesn't have to be necessarily less than 60, predominantly less than 60. And, as I was reading this, I've moved away from the term cryptogenic stroke. If a patient has a stroke of undetermined etiology, and then you figure out there's a PFO, that's now a PFO-related stroke. It's no longer cryptogenic. So PFO-related strokes should be treated with PFO closure. All right, so let's talk about the cardioform septal occluder and its characteristics. The cardioform septal occluder is essentially a platinum-filled nitinol wire frame covered with expanded PTFE that when fully deployed assumes a double disc shape in which each disc has identical diameter. GORE became GORE because of its application of ePTFE, and so the cardioform is no exception. So you see here this double disc device. We'll go into some details about how the discs are formed. This is what it looks like fluoroscopically on your far right with 2 discs and 3 islets. The device itself actually consists of the occluder, the delivery sheath, and the handle, which comes as a set. So you do not need a separate sheath or delivery system for this. It all comes as one in the box. All right, so what are the properties of the cardioform septal occluder? And this is where I think it differentiates itself. First, the ePTFE is known to have low thrombogenicity and a minimal inflammatory response, which leads to rapid endothelialization. You see here just an example in the 30-day canine model of the glistening endothelium around this device. And there's a long track record of ePTFE in medical implantable devices, which this device leverages. We'll talk about this a little bit more with the clinical trials, but in the REDUCE trial, patients randomly assigned to the cardioform could receive just 3 days of aspirin and clopidogrel followed by aspirin monotherapy. So, there's a very, very abbreviated dual antiplatelet therapy requirement in these patients, which I think is a good thing. There's also very minimal nitinol in this device. The nitinol only acts as a frame for these ePTFE pedals, which we'll drill down upon. Also, the nitinol is really easy to see fluoroscopically because the nitinol tubes are actually filled with platinum, which enhances fluoroscopic visibility. There's extremely little nitinol actually exposed to the circulating blood because the actually ePTFE covers most of the nitinol itself. So very little nitinol is actually leached into the bloodstream after implantation. So let's drill down a little bit on the discs themselves. So these are not just simple nitinol discs. Each disc consists of 5 petals, which can conform to the septal wall. So they almost act independently. Now there's one sheet of ePTFE, so they're not completely independent. But because there are these petals and it's only a nitinol frame, the device can conform nicely to the concavity of the interatrial septum around the aortic roots and around the septum secundum. And you see, if you look here on the fluoroscopic image, you can actually see the 5 petals themselves. And we'll talk about when we implant the device, when we look at our result before we release it, is to really look at those petals and how they're sitting. In terms of device size with the cardioform is defined by the diameter of the disc. Remember, the 2 discs are of equal size. So if the diameter of the disc is, a 25 millimeter device has a disc diameter of 25 millimeters. The device sizes are 20, 25, and 30. Okay, so there's limited choices, but we'll talk about this in that the default size for almost all PFOs, I'd say 80 to 90% of PFOs, will be 25 millimeters. Very straightforward. Okay. So again, unlike, for example, say the AMPLATZ or septal occluder, which is defined by the waist diameter, the cardioform septal occluder is defined, the size is defined by the disc diameter. The delivery sheath, as I mentioned, is incorporated into the design of the occluder itself. So it comes with this system. In adults, we usually do this over a wire. So you're going to need to use an 11 French sheath in the groin, a pinnacle sheath in the right femoral vein. The sheath itself has a 10 French outer diameter and a very short monorail for your 035 wire. It's really short, shorter than you think it's going to be. So it's a good idea to look down when you're loading the delivery sheath onto the wire to make sure that the wire goes through the rapid exchange port rather than going into the sheath itself. It won't be able to go much farther because the end of your device is sitting right proximal to the rapid exchange port. But I'm always impressed about how short it is, and you always think it's going to be longer than it is. So just be aware of that. This is a nice, robust sheath. It's braided. There's a nice curve in it, so it's just a gentle curve, which will allow you to cross the septum, and it's 75 centimeters in length. There's a radiopaque distal marker band, which you can follow, and it can fluoroscopically, you can usually tell whether you're across the septum or not, just by the relationship of that radiopaque marker in the vertebral column or the spine in the straight AP projection. So you have the occluder itself, five petals with nidinal frame, sized by the diameter of the disc. You have the delivery sheath, which is 10 French outer diameter, which is a rapid exchange. And then you have the delivery system handle. And this is it here in front of us. Let's walk through it. We'll walk through it from right to left. So first, there's a slider, and there's this Z track, they call it. Well, it's more of a U if you ask me, but it'll come out like this when it's coming out of the package, where your device will be, the occluder will be outside the delivery sheath. So you'll need to load the device, and all you do to load the device is to slide the slider away from you along this track, and then down and then back. And that's going to bring in the right disc, then the left disc entirely. There's a flush port. So what we do is we load the device and then flush the system. You'll need a stopcock there to do that. There is there's a luer lock here. This delivery catheter, there's a delivery catheter which enters the delivery sheath. So this retrieval luer is going to come into play if you ever want, after you've locked the device and you want to get it back, because you want to abort the procedure. It's very easy. You just loosen the luer lock and you pull the entire handle back into here, and that'll bring the device into the delivery sheath in a very straightforward fashion. There are these two red tabs. Red meaning stop, think before you pull them, okay? This is the locking mechanism. When it's time for us to lock the device after we deployed it, we're going to slide this red tab back. And finally, after we've locked the device, we like the way it looks, we're going to pull our retrieval cord. This basically pulls off like a beer can tab or a soda can tab. You'll be able to pull that line out, all right? So the key thing is to understand the slider and the lock, and we'll go through that through our case. So that's the device, occluder, delivery sheath, handle. Now let's talk about our PFO and the different types of PFO and how we're actually going to close this. So when you look at a PFO, there are various anatomies, and I think there are, I like to categorize the anatomy of a PFO into 5 classes. Tip of the hat to John LaSala, who I don't think I stole this from John, but I heard him speak about it once, and it kind of jived with what I also explained to my fellows, so I will give him credit for it. There are 5 categories of PFOs. One has a long, rigid tunnel. You can see this on TE or ICE. The second has a thick septum secundum. The third has an aneurysmal septum. The fourth has some combination of those factors. And the fifth has none of those factors at all. So any of those first 4 categories, we consider to be a complex PFO. And what are you going to do there? Basically, you're going to upsize the size of your device. You're going to use a 30 millimeter device, not a 25. And you may have to use some special maneuvers during delivery. That goes beyond my talk today, although if you have questions, I can certainly chat about them or talk about them in the question and answer period. If the PFO has none of these factors, this is a simple PFO, you're going to use a 25 millimeter device. All right, so let's talk about the setup for PFO closure. And I think this is a best practice. Conscious sedation with ICE. Okay, if you're starting out your practice, you need TE, that's fine. I'd really encourage you to get comfortable with intracardiac echocardiography. These are young patients. We want a no-touch procedure. We want few complications. And I think that just being able to do it with conscious sedation is the way to go. I put 2 11 French sheaths in the right femoral vein. Depending on your ICE you like to use, the AccuSon system has an 8 French. You can use a 9 French sheath, or the St. Jude has a 8 French ICE as well. So you can use a 9 French if you like. I prefer the 10 French system. It's a little more robust. The 10 French AccuSon, it's a little more responsive in its maneuvers and has a little bit, I think, better 2D quality, but that's my personal preference. I use a single figure of 8 stitch to close both sheaths, to close the venotomy site at the end of the case, unless the patient has severe obesity or even modest obesity, where I may consider pre-closing each sheath. So take-home messages: conscious sedation, 2 sheaths with ICE, figure of 8 stitch. Now, if you're going to use both groins, for some reason you don't want to use one groin, that's fine. I would recommend you use the left femoral vein for the ICE and put in a long sheath, a 25 centimeter sheath, to get around the pelvis up into the IVC. So you do not have to do much maneuvering of your ICE catheter to get up into the right atrium. To repeat, if you're going to use both groins, long sheath on the left, short sheath on the right. I tend to also, if I'm using 2 sheaths on the right side, I put the ICE in the lower sheath. It just seems to be, doesn't get in the way as much. All right, I mentioned how important ICE is. So I think if we're going to talk about PFO closure, we also have to be experts in intracardiac echo if we're going to use that. So I thought I would just show you quickly about how to identify and the key views of the interatrial septum with intracardiac echo. So we'll walk through this several times. So I have a still image right now on the right side. And let's look at this. This again is using the AccuSon Biosense Webster, I guess, / Siemens probe now, but certainly you can use any other 2D ICE. St. Jude makes a fine one. How I try to describe this to my fellows is I look at this letter A, that's the tip of your catheter. Okay, so if you advance the catheter, the image is going to slide to the left. If you withdraw the catheter, the image is going to slide to the right. If you want to see something that is close to the letter A up here, okay, you need to pull your probe back. That's going to be a posterior flex on your catheter. If you want to get closer to something on the screen, you're going to go anterior. The bottom line is this, is that your PFO in the interatrial septum is going to be a posterior, it's going to be a clockwise and then posterior flexion. So what we're going to do, I'll start playing this here, is I'm going to clock my probe slowly till I see the mitral valve. The mitral valve disappears, then I flex posteriorly and advance the probe. That went pretty fast, but there we are at the PFO in the long axis view. Let's do that again. I'm going to start from the top. The first thing you want to do is start at the home view. So what is the home view? The home view is where you see the right atrium, the tricuspid valve, the right ventricle, and the right ventricular outflow tract. You can actually see the pulmonic valve right here. If you're using the AccuSun's catheter, you'll then lock it, okay, to make it more rigid. The St. Jude doesn't have a lock, it doesn't matter. You're then going to clock the catheter. That moves it posteriorly with respect to the heart, okay, not with respect to the body of the patient. So as you do that, you begin to, you clock the catheter. Right there's the mitral. Oh, let me pause right there. Good. There's the mitral valve. In fact, as we clock it, this is the mitral valve. You're going to be able to see the left atrial appendage a little bit as we continue to clock it. Right there. I continue to clock it more. There are the pulmonary veins, okay? You can actually see that really nicely. These are the pulmonary veins, and this is the intraatrial septum. When you use a posterior dial, that's going to move the entire intraatrial septum down because you're flexing the catheter back. So let's see, I'm going to do that right about now. There it is, and then I advance everything to center it up. Now the left-right dial can help clean things up a little bit. Usually you have to turn the left-right dial a little bit to the right, which is away from you. So not to flog this too much, we're going to walk through this one more time because it's just so important. Home view, clock, 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 mitral valve disappears, posterior, advance the catheter. Right there. Left-right knob to clean things up. It's a beautiful view. You see the pulmonary veins behind you there. What's also important is pattern recognition. So on the left here is a fluoroscopic image of the long axis of the interatrial septum in the straight AP view. So your probe is looking up and to the right in the straight AP view. And you see now this is the same view on ICE. This is the septum secundum on the right, the septum primum on the left. This is the SVC. This is a helix device. For those of you who have been doing PFOs for a while, this was the version before the cardioform. All right, how do you get the short axis view of the aorta? That's going to be our complementary view when we're assessing our PFO at baseline and also are assessing our result. So there are two ways to get to the short axis view of the septum with ICE. The first way is to continue to clock the entire catheter. So again, this is in AP. Remember, we were up and to the left before. I've clocked the catheter a little more than 90 degrees. And now I'm actually underneath the aortic valve looking up. And that's what you see here, the aortic valve, septum secundum, septum primum, and our helix device here splaying around the aorta. Another way to get to the short axis is just to use your left-right knob, which is the knob closer to you on the AccuSun device, and for that matter, the St. Jude device, and you just flex it away from you. That will usually bring you 90 degrees underneath the aortic valve, and you can see the short axis. Okay, so those are our key ICE images, ICE views: long axis, SVC, IVC, short axis, aorta, and that would be the posterior superior rim of the interatrial septum. For the long axis view, you're on the straight AP, you're looking up and to the right, and otherwise you're looking up and to the left. Okay, so here now is a case. So let's go through our case. This is a 37-year-old male who has had an ischemic stroke and no other risk factors. This is the baseline bubble study on ICE. He had gotten a TTE and a TE, which showed a positive bubble study. I'm kind of particular with my bubble studies, a good bubble study, and I've this is revised a bit from Bob Siegel's approach up at Cedars-Sinai for TEs at transthoracic echoes, where a good bubble study for a transthoracic or TE is 1 cc of blood, 8 cc's of saline, 1 cc of air. I sort of flip it around because we have a sheath, so we can get a lot of blood. I use 8 mLs of blood, 1 ml of saline, 1 ml of air. Just use the stopcock in your sheath to allow you to mix your cocktail to create bubbles, and you slowly inject. We are in a pretty much a long axis view here. I could serve, you can see, you see the mitral valve a little bit right here. I could serve to clock my catheter just a little bit. Towards the end of the run, that's a pure long axis view. This is the septum secundum. Here's the septum primum. It's a little bit of a redundant septum primum, but nothing terrible. You see clearly a positive bubble study. So I'm looking at this now, and I see that the septum secundum is thin. It's less than 10 to 15 millimeters in thickness. There's no aneurysmal septum. There's not a sweep of more than 15 millimeters total, or 10 millimeters in one direction or the other. There's not much of a tunnel either. You can see the bubbles come out right about here. Okay, and there's no combination of factors. So this I would call a simple PFO. So let's go step by step about how you close a PFO with a cardioform. So what I first do is advance a 5 or 6 French multi-purpose catheter with a regular J into the base of the right atrium. You point your multi-purpose catheter up and to the right in the straight AP view. And if it's a big PFO, it'll usually just push that wire up, it'll go. You can cheat and use ice if you want to watch your wire go through. Once that wire goes through, you advance and this is a regular 035J wire. I don't use a stiff wire from the get-go. I do not use a Terumo wire or an angle J. Once your wire is through into the left atrium, just keep it in the body of the left atrium unless it's clearly up into the pulmonary vein, because your goal is to get in the left upper pulmonary vein. Advance your multi-purpose catheter into the mid portion of the left atrium. Withdraw your wire, clock your catheter a little bit, and re-advance your wire. That'll get you into the pulmonary vein. Here on ice, you can also confirm you're in the pulmonary vein because my wire is far away from where the left atrial appendage would be. You can see you can counterclock your ice catheter here and look for the mitral valve in the LAA, and you'd be able to see it. Once your wire is in the upper pulmonary vein, advance your multi-purpose, pull out your pull out your regular J and advance an extra stiff AMPLATZ wire. I like to use the AMPLATZ extra stiff J wire that has a 3 centimeter segment that's floppy, not the 7 centimeter segment that's floppy. That's the Boston Scientific one. Because if you do that, it's going to be floppy all the way to the right atrium. It defeats the whole purpose. Here now what we're going to do, I'm going to pause this here for a second before we actually show this. I want you to see very nicely, I'm in the straight AP view here, that my wire is clearly in the left upper pulmonary vein. These are pattern recognition. At times, your wire will only go into the right upper pulmonary vein. It seems very strange. It goes up to the left upper corner. Excuse me, to us at least. The patient's right upper corner, but our left upper corner. Little trick or tip, if that happens, suspect that you have a long, stiff tunnel that's forcing you into the right upper pulmonary vein. You may want to upsize to a 30 millimeter device. Now what we're going to do, once our stiff wire is up into the left upper pulmonary vein, we're going to walk out our multi-purpose catheter. And I should also say this is a good opportunity once your stiff wire is across the intraatrial septum, is to step back and assess the PFO. Now that you have a stiff wire, if your stiff wire splays the septum well open, like it's wide open, that's a situation where you may want to upsize to a 30 millimeter device because you have a very soft and redundant septum primum, okay? This is my stiff wires across here. It's still a pretty small PFO. It's not flexing open very much. I'm going to stick with my 25 millimeter device. So now I'm advancing the delivery system up across the PFO. And I can tell you that I know I'm across the PFO here. First, I can see on my ICE, but I can also submit to you in the straight AP view, the PFO, the interatrial septum, in most people is going to be sort of on the left side of the vertebral column. I also want to mention to you guys here, let me just play this. You remove your wire, so then you can then advance your occluder out of the delivery sheath. If you forget to remove your wire, it can be done, but you're gonna get a lot of resistance advancing your occluder. So now our wire is out. We are now going to form the left atrial disc. Now, this is where you can do it elegantly or not so elegantly. We are going to deploy our left atrial disc by sliding the slider, the actuator, to the left, from the right side to the left. That the first few centimeters of that slide is going to advance the occluder system within the delivery sheath, because it has to get past the rapid exchange port, right? We talked about to extrude itself out of the delivery sheath. There is a bit of a throw at the beginning of the left disc formation, okay? So what would happen if you just sat here and slid the left disc, slid the slider all the way to the left, this device would come out like this. We don't want to actually bang into the back of the left atrium. So a very elegant way to do it is actually to advance that slider, but at the same time, withdraw the handle. So what you're doing there basically is unsheathing the device. Look at here. This point is going to stay exactly where it is on fluoro as I slide back the handle, okay? It's going to go, I'm sliding back the handle until I cannot move my slider anymore, right? And it's at the first phase of that Z track. And this is what that looks like here, excuse me, before I start. I'm going to pause this. Okay, so what this looks like now is I have my long axis view, my delivery sheath is here, and I've extruded the beginnings of the left atrial disc into the mid left atrium. I am now going to form the left atrial disc. Another little trick is sometimes your sheath sort of hugs the wall of the left atrium here. If that's the case, you may want to clock the whole system a little bit, the handle and the delivery sheath together, and slide the handle, and that'll move you away from the aortic aspect of the left atrium. I'm now going to just continue to slide that slider to the left while I'm watching under fluoro. And this is now what happens here is it forms the left disc like that. This is what it looks like on fluoro. I'm just going to form that left disc. Fluoroscopically, I get to where that left disc is flat, and then I stop. That's usually about halfway along the track of the slider. If I do too much, I just slide it back. It's not a big deal. You see very nicely here that I have now the left disc in the mid part of the left atrium. What I'm now going to do is pull the entire system back en bloc to the intraatrial septum. Very nicely seen on the long axis. You can also do this on the short axis, whatever is easiest. And you see here, the system as a whole is pulling back. It's really easy. You just pull the handle back. The slider is not going to move. Just move it as one. And I'm moving it back until at least one part of the device is touching the interatrial septum. Remember that the interatrial septum is concave, so that it may be that you're going to be touching one aspect of the interatrial septum, but not the other aspect. That is fine. What you see here on this PFO as well is as I pull back, watch the left disc up here. At a certain point, it begins to flex. You see that right there? I'm touching the wall. That's actually the aortic aspect of the interatrial septum. So that's perfect right there. So now I keep it there. I'm going to form the right atrial disc. And I'm going to do that just by continuing to move my slider over to the left. So there's my slider form, and I just formed the right disc. I'm just pushing it out, okay? I like to store this on ice and Cine just so I can review. And you see what's nice about this device is that the right disc forms, from the sheath out. So it pushes out rather than from the left side back, so that you're going to be able to grab that septum as if you're touching the interatrial septum anywhere with your left atrial disc. And I can look at this. I see very nicely I've grasped the septum secundum. I've grasped the septum primum. The right side of the device stays on the right. The left side of the device is staying on the left. So now we have to assess our result. I first do this by intracardiac echo. And it's important to do this in general in our two views we talked about, which is the long axis view and the short axis view. Again, I'm going to talk a lot about this because there's really very few ways you can go wrong with a simple PFO closure, is if you don't grab the septum secundum, all right? And here is the septum secundum. It's the thicker part of the septum. It's on the right when you do intracardiac echo. I like to joke around is you need a septum secundum sandwich, all right? So our right disc and our left discs have sandwiched that septum. You can also see very nicely the septum primum bouncing in between the discs here. And I've also grabbed the septum secundum very nicely on the short axis view, that little wedge right there. You don't need to do a tug or anything like that. It's very clear. So I like this, all right? And then if you want to be thorough and compulsive, which you should always be, is you should now look on fluoroscopy to see whether you have good device placement. Now I'm going to move my II. I'm going to go steep left anterior oblique with a slight cranial. So I see the two discs. I get the parallax out of the two discs. And I see the separation between the two discs. This is very nice because what I see here is that I have two discs without any overlapping of wires, which means that my two discs are on the correct side of the septum on each side. I can also see that there are no petals hanging off on the right side. It's all on the left. I'm going to use this opportunity because the next thing we're going to do is we're going to lock the device. Just talk about what this device looks like on X-ray. This is my delivery sheath. And there's that radiopaque marker on the end of the delivery sheath. I then have an inner catheter here. This inner catheter is actually that catheter that you can, if you had to unlock the Luer lock on the proximal sheath, that's the catheter you can pull back to bail out if you need to. We're not going to do that now. There are three eyelets to this device. There's the right atrial eyelet, there's a central eyelet, and there's a left atrial eyelet. Three eyelets. You can see before we lock the device, they're very close together and all aligned. Finally, and I think I'm going to show this on the next one. That's there. Actually, I'm going to go back one. You also see this black line right here. You have to lean. I have to lean into my screen a little bit to see it. There's a black line here. What is that black line? That black line actually is a piece of nidinal that goes up through all the eyelets and around here and is screwed on to the left atrial eyelet there, I believe. Okay. And so what's going to happen when we lock this device is we're going to liberate this little piece of nidinal, which has a hook on it. And it's going to come and hook out. It's going to release itself like a little pigtail and keep that device, keep it nice and snug together. How do we lock this device? I mentioned on the handle, there's a red button, You're going to pinch that red button and slide it back. And by sliding it back, what you're doing is actually pulling back on a little mandrel inside this device. This is sort of the sausage, which you really don't need to know about. But if you slide back that slider, excuse me, the lock slider, that pulls that mandrel back, and that liberates that nidinal to do its thing. Let's just see what happens there. I do this under Cine. I've then locked the device, and you see what's happened? That black line has disappeared. It's hard to actually appreciate it, but it's going to form right there. Let me see if I can pause it. Move this here. Hold on a sec. Right there. It's a little hard to appreciate. I believe sometimes hard to see. There's a little pigtail of nitinol right here. You see a couple of things happen. Number one, that blocked line disappears. Number two, the eyelets loosen up a little bit. That's normal because what's happening is this device is conforming to the interatrial septum with limited tension. That's what you want. Third is you see the device has moved a little bit away from our delivery catheter. That's because it's no longer connected by rigid nitinol. It's only connected to our delivery system by the suture retrieval cord. Let's watch that again. Lock the device, and then it is released. If I didn't like what this looked like now, very easy. All I would need to do is loosen up that lure lock we talked about, put some tension on the system, and pull back the handle as a system, and that device would fold back into this delivery sheath, and we would still be on the left atrium, and I could put a wire up and then exchange out for another device if we needed to do that. So now we're connected to our system, to our occluder, only by the suture retrieval cord. The reason why we have that suture retrieval cord is for if we want to retrieve the device using that delivery catheter technique I mentioned. But now we like it. It looks great. I guess we can do one more check, which we should always do. So I'm checking again to make sure that everything looks fine, because if it doesn't, I can always just retrieve it by pulling it back in to the delivery sheath. Septum secundum, terrific. Septum primum looks good. Nice flat device. Looking very nice in the short axis as well. This is a great result. I do it at fluoro here. You can see here on fluoro, it looks very nice. There are no wires overlapping. This wedge here is normal. That's the splay around the aorta. So now what I'm going to do is pull the retrieval cord, basically pop that soda tab. I mentioned that red tab, and then slowly pull on the retrieval cord. That retrieval cord goes from the handle all the way up through the delivery catheter, through this inner catheter, up into the right atrial eyelet, and back all the way down to the handle. So it's a loop. So all you're going to do now is pull that out. So you're undoing that loop. And you'll notice when you're completely free for two reasons. One, you'll see a little bit of heme on that suture retrieval cord. And also the device will move a little bit because now it's completely free. There's no tension at all. Let me see that if I have this here. There, do you see how it moved all of a sudden there? That's beautiful. So that is when the retrieval cord comes all the way out. So now there's zero tension at all. One of the benefits of the CardioForm device for ASD closure, as well as for PFO closure, is when you have that lock, you've relieved most of the tension on the device. So you can get a pretty much tension-free look at what the device is going to look like on final release. Although once you remove the suture retrieval cord, there may be a slight bit more movement because now you have no tension at all pulling down towards the IVC. All right, here's the final bubble study. The party is over, as we like to say. No more bubbles crossing. This is a terrific final result. So I want to just talk a little bit about mode of failure. The most common mode of failure for a simple septum secundum, I suppose, is to not recognize that it's simple, that it's complex, but that's because you're not grabbing the septum secundum. So again, here's a good example from some time ago of a patient who was snoring like crazy during the procedure. That's called a Mueller phenomenon, as opposed to a Mueller maneuver, as opposed to a Valsalva maneuver. The Mueller maneuver is inspiration against a closed epiglottis, okay? And it can cause significant dispersion of the interatrial septum. So here's our septum secundum, here's the septum primum, and you see how much dispersion there is here. I put in a device, and then as the patient was snoring, look what happened. You've lost the septum secundum, we have. This should be sandwiched around that septum secundum, but it's fallen into the PFO itself. So that's a bad day at the office if you release that, okay? This is actually, it was still connected to the suture retrieval cord. I can just pull it right back in, no problems. But this device, in theory, could embolize. Usually what will happen is that it's just adherent to the septum primum, and you won't get, you'll have a big residual bubble study because you're not closing the defect. So just something to remember. This is now after I put in a bigger device, a longer device. You can see how I've really captured that septum secundum now. It fell down before, and now it's captured. And you'll see that often on fluoro, after you've deployed the right atrial disc, is if it won't look splayed, it'll look like the discs are flat together, like you just took it out of the package. So this is a case of a very thick, just one complex PFO example, a thick septum secundum. You can see how thick that is. Just eyeballing it, it's certainly more than 10 millimeters. And I think I upsized to a 30, yeah, this is a 30 millimeter device here. And you see how I've really grabbed real estate on that septum secundum. I'm not gonna let that puppy fall down. And you can see here, when I lock, this is me locking the device, how that pretty enormous splay across that thick septum secundum, but that's okay. That's why you gotta just get a little more nitinol, a little bit bigger disc to really grab it securely. So this is my summary slide, my last slide here. So the CardioForm Septal Occluder device is a double disc device consisting of independent nitinol frame petals with EPTFE fabric. There's an incorporated delivery sheath and handle to facilitate easy deployment, repositioning, and retrieval if needed. Your default size is a 25, and upsize to a 30 if there's an aneurysmal septum, a thick septum secundum, a long rigid tunnel, and just don't forget to eat your septum secundum sandwich. #1 reason for procedural failure.